Hello everyone, my name is David Garcia. I'm a PhD student at Universidad Carlos III in Madrid, Spain. Today I'm going to present my work called Augmented Reality Visualization for Craniosynostosis Surgery. I will start with a brief introduction to the topic. So as most of you know, cranial sutures are the fibrous tissues uniting the cranial bones during the first years of life. The main functions of these sutures are to allow for skull deformation during birth and to allow for skull expansion during brain growth. These sutures are the major growth centers during craniofacial development. So what happens when one of these sutures is closed before it's shut? Then craniosynostosis occurs. So craniosynostosis is defined as a birth defect which is characterized by the premature closure of one or more cranial sutures. This condition affects 1 in every 2,000 live births worldwide, and the fusion of the sutures leads to morphological abnormalities due to the restriction of the growth vectors, which can be classified according to the affected sutures. Apart from the morphological abnormalities, functional consequences can also occur, such as elevated intracranial pressure or impaired brain growth. Surgical correction is the preferred treatment for most cases, and the objective of the surgery is to normalize the calvarial shape by increasing the intracranial volume and reducing the risk of elevated intracranial pressure. Surgery is usually performed during the first year of life in order to maximize reossification. Surgery has 3 steps. First, a bicoronal incision is performed in order to expose the cranial surface. Then, osteotomy is performed to resect the affected bone tissue. And finally, this affected bone tissue is going to be remodeled by bending and cutting into different fragments to achieve the desired target shape. Then, once the bone has been remodeled, it is fixed into the patient using resolvable plates, and that's the end of the surgery. This surgical correction is highly dependent on the experience of the surgeon and highly subjective. Therefore, although a pretty good virtual plan can be performed before surgery, an accurate translation of this plan into surgery is almost impossible. Therefore, multiple approaches have been proposed to improve surgical outcomes. For instance, Hotfeld et al. In 2014 proposed the use of a stereotactic frame to control bone fragment positioning, but this technique is characterized by the complexity, it is invasive, and it also increases surgical time. Later, Kovacs et al. Proposed the use of intraoperative computed tomography imaging to control cranial bone remodeling, but the problem of this technique is the exposure of the infant to ionizing radiation and also the increased operative time. Last year we proposed a navigation system which was validated and presented a high accuracy, but the main limitations of the system is that this system requires an expensive optical tracking system which is not always available in all centers, and also that the information must be visualized on a different screen. Therefore, augmented reality has been proposed to avoid the surgeons looking at different points of view during the surgery and therefore projecting everything on the surgical field. Last year, Han et al. Proposed an augmented reality system for craniosynostosis where the virtual models can be overlaid on the surgical field using augmented reality, and this virtual data can be aligned with the patient anatomy using augmented reality markers that can be attached to the mouth of the patient using occlusal splines. The main limitations of this system are, first, that the visualization is done on an external screen, so no improvements with respect to the navigation. An external camera is used for marker tracking, and a CT scan is required for the localization of the augmented reality marker and the registration of the virtual data. Also, in this study, they didn't evaluate the accuracy of the system. They just measured qualitative metrics. And finally, the large distance between the augmented reality marker in the mouth and the region of interest for the surgery, the cranial vault, is pretty large, and therefore we expect a low accuracy. Therefore, the objective of this study is to evaluate a novel workflow for augmented reality guidance during craniosynostosis surgery. This workflow is based on combining 3D printed markers with intraoperative 3D photograph. Regarding the materials of this study, we use 3D printed augmented reality markers to track and align the virtual data with the patient anatomy. Also, we use a structural light 3D scanner for the acquisition of 3D photographs. Also, for the performance evaluation, we designed and manufactured 3D printed simulation phantoms. We used a smartphone with a smartphone application for the augmented reality visualization and tracking. And finally, for the performance evaluation, we used a validated navigation system as a gold standard. Regarding the database available for this study, we included the data of 3 patients presenting metopic craniosynostosis and diagnosed in our center. The available data for each patient includes the preoperative CT scan and a virtual surgical plan, which has been customized and defined by specialized craniofacial surgeons. This virtual plan includes the definition of the osteotomy, so where to cut the bone tissue, and also a definition of the target shape that the surgeons want to achieve after surgery. For the performance evaluation, we manufactured two different types of phantoms. First, an osteotomy phantom to simulate the bone resection, and a remodeling phantom to simulate cranial bone remodeling and bone fragment positioning. These 2 types of phantoms were manufactured for each of the patients under study, using the CT scans as a reference. These phantoms were manufactured using PLA material to simulate bone tissue and silicone material to simulate soft tissue. Our augmented reality workflow has 4 main steps. The first step is the attachment of the augmented reality markers. So in this example with the phantom, we attach the augmented reality markers on both sides of the cranium. So 2 markers, one on the left side, one on the right side. These markers are pretty small and low weight and can be easily attached to the bone tissue surface using resolvable pins. Then, the next step after the markers has been attached is to localize the markers. So we need to know where the markers are with respect to the anatomy of the patient in order to know where to position the virtual data. So to do that, we used 3D photography. So we use a structural light scanner device to perform a 3D photograph, which contains the geometric and textural information of the anatomy. With this 3D photograph, we can compute a registration with the preoperative CT scan using surface-to-surface registration algorithms in order to have an idea of the position of the 3D photograph with respect to the CT scan, which is our reference for the patient anatomy. Finally, for the registration, we can take into account the 3D photograph to identify the augmented reality marker position in the 3D photograph using by identifying some reference landmarks on the pattern of the markers. This way, we can register the virtual data with the patient anatomy, and we can know where to position that virtual data with respect to the augmented reality markers. Finally, for the augmented reality visualization, we developed a software application called Cranio-AR, which was developed on Unity platform and uses a Buforia development kit for the tracking of the augmented reality markers. Finally, this software application is compatible with smartphones, head-mounted displays such as HoloLens, and external cameras. This application has 2 visualization modes, osteotomy mode and remodeling mode. For the osteotomy mode, the application detects the augmented reality markers on each side of the cranium and projects the osteotomy lines, the virtual models of the osteotomy lines, on the surface of the patient or the phantom. These lines are projected as red lines, as you can see in the video, and the marker can be seen if it is tracked or not by the green boundary surrounding the marker. These lines indicate the surgeons where to cut the fragments as defined in the preoperative virtual plan. For the remodeling mode, the marker is tracked by the application and it projects, using augmented reality, the target position of the remodeled bones in order to achieve the desired target shape defined during the preoperative virtual plan. The optimal distance for the augmented reality marker detection is below 30 centimeters, between 20 and 30 centimeters, and the minimum and maximum distance is 5 and 60 centimeters respectively. For the performance evaluation, we ask 2 users to perform surgical simulations on 3 different phantoms based on real patients. For each phantom, we ask the users to perform 3 complete surgical simulations. This surgical simulation consists of 3 steps. First, a registration of the virtual data with the patient anatomy using structural data scanning, 3D photography. Then the osteotomy or bone resection. And then to simulate the bone remodeling or bone fragment positioning. For the performance evaluation, we used a navigation system as a gold standard, which consists of an optical tracking system. So we asked the user to use the smartphone app to visualize the surgical field, the simulated surgical field, to detect the marker, and to record the projected osteotomy line using a track tool, which is tracked, whose position is tracked by the optical tracking system. Then the user moves the track tool along the osteotomy line, the different osteotomy lines, and we recorded points along these lines. Therefore, we can measure 2 different metrics, the linear error for the osteotomy and the angular error. For the remodeling, we followed a similar approach. We asked the user to place the different bone fragments in the position defined by the augmented reality visualization, which is the one defined during the virtual plan. And in order to compute the error of this positioning, we use the optical tracking system to measure the position of those fragments by computing the position of different landmarks along the fragments. And we computed 2 different metrics, the fragment translation error and the fragment rotation error. Finally, after testing on simulation phantoms, we tested our system on the complete augmented reality workflow in 2 craniosynostosis surgeries. The augmented reality markers were sterilized before surgery using ethylene oxide at 37 degrees temperature. Then, although the markers used for the surgical deployment had a different pattern than the ones used for simulation in the phantoms, these markers were presented similar characteristics and were manufactured in a similar way. The augmented reality markers were attached on both sides of the cranium, left and right side, using resolvable pins, which were removed after surgery. Finally, due to the lack of a sterile cover for the smartphone, to put the smartphone inside the operating room, we used an external camera for marker tracking. In order to evaluate the performance of our system in the operating room, we asked 9 specialized craniofacial surgeons to fill an anonymous questionnaire survey about the augmented reality visualization in craniosynostosis surgery. Regarding the results of this study, regarding the alignment, so for the alignment of the virtual data with the patient anatomy, we used the information of the 3D photography and the preoperative CT scan to align both, and the average alignment error of this registration was 0.15 millimeters. Then, for the identification of the augmented reality marker, the average error for the localization was 0.31 millimeters. These results demonstrate the accurate alignment of the virtual data with the patient anatomy represented in the preoperative CT imaging. After that, we evaluated the performance of the augmented reality visualization to guide the osteotomy in simulation phantoms. We measured the linear error and the angular error of the osteotomy in each of the different cutting planes. The average osteotomy linear error was 0.62 millimeters and the average angular deviation was 1.8 degrees. Those cutting planes with the higher errors were the frontozygomatic plane, the mid-sagittal plane, and the frontonasal planes. These planes correspond to those osteotomy lines farther away from the augmented reality markers, and therefore a higher error was expected. For the remodeling, we measured after positioning the fragments, we measured the errors in the translation and the rotation of the final position of the fragments with respect to the real position defined during the preoperative virtual plan. Average translation error was 0.69 millimeters and average rotation error was 0.4 degrees. Regarding the feedback from the specialized surgeons, we can see that most surgeons agree that this system is suitable for surgery, that it provides intuitive guidance and visualization in the operating room, but most of them agree that specialized training is required for the surgeons to perform well in surgeries using augmented reality. Finally, regarding the visualization platform, the preferred visualization platforms were the head-mounted displays and smartphones, which are preferred over external screens. Finally, after testing in real surgeries, we found that the illumination conditions in the operating room are suitable for marker tracking and augmented reality visualization, that we can achieve a fast augmented reality marker detection and accurate tracking the whole time. Finally, these augmented reality markers can be safely sterilized before surgery without the risk of deformations. Also, that the 3D photography can be easily used inside the operating room for fast and accurate three-dimensional modeling of the patient anatomy. And also, we found from the feedback of the surgeons that all the different steps in our workflow are feasible to be integrated into the current surgical workflow. So to conclude, we have seen that 3D photography enables an accurate registration of the virtual data with the patient anatomy, which is a common problem in augmented reality. Also, the presence of augmented reality markers attached close to the region of interest enabled an accurate tracking of the anatomy and alignment of the virtual data. Finally, after several surgical simulations on phantoms, we found that the augmented reality can accurately guide bone osteotomy and bone fragment remodeling in craniosynostosis surgery. The developed software application is compatible for head-mounted displays, smartphones and external screens, and therefore the visualization platform can be selected according to surgical needs and preferences. After successfully testing our system in real surgery, we found that the illumination conditions in the OR are suitable for marker tracking and visualization, that all the steps in our workflow are feasible to be integrated into the craniosynostosis surgical workflow, providing to the surgeons intuitive and valuable guidance during surgery, which will lead to an accurate translation of the preoperative virtual plan into the operating room, which right now is based on the subjective artistic judgment of the surgeons. So we believe that this augmented reality technology will improve the reproducibility of the surgeries and will contribute to the reduction of the intersurgeon variability. Finally, we can say that this augmented reality technology can be combined with existing navigation system to combine the real-time feedback and metrics provided by the navigation with the integrated visualization within the surgical field provided by the augmented reality. Regarding the 3D photography, in our workflow we use the 3D photography for the registration of the virtual data and the patient anatomy, but this technology has more application. This technology can be useful also for the intraoperative surgical outcome analysis and for the postoperative patient follow-up. So the integration of this technology into the workflow will have more benefits for the management of craniosynostosis. I would like to thank these institutions for the funding and thank you very much for your attention.